Afternoon, good morning, and good afternoon to all of you joining. My name is Jennifer Leopold. I'm the Communications and Knowledge Management Director for the Health Finance and Governance Project. I want to welcome you to today's webinar on USAID's Health System Assessment Approach. Before we get started, I want to address any potential problems that anyone may be having with audio. Instructions here are on the slide, and if there are other technical issues, hopefully people will reach out with the chat box, but hopefully this will get everybody connected. Go ahead and advance. So today we're going to be working and talking about the health system assessment approach. You want to go ahead and advance and go through? Yep. So we've got a lot packed into the hour, but we really want to get to questions at the end. So everyone will do their best to stick to time. Today we're going to have an overview and background of the HSAA. We're going to go into more detail for service delivery, the modules on health financing, and also on medical products, vaccines, and technologies. Then we'll talk a bit about systems thinking methodologies, where you can find the HSAA, the version 3.0, and then flip into questions. So for Q&A, again, I said we'll have some time for questions at the end. As we go through the presentations, take a minute to send your questions in the Q&A box. We'll compile those and do our best to get to those at the end. Again, the chat line in particular, you can direct specifically to me or have any technical issues. Please don't send the Q&A to the chat box. We won't see those as easily. Make sure that they are in the Q&A bar. Okay. So our speakers today, we're super excited to have a great panel of speakers. I'll properly introduce them as we go through the agenda. But we have Jodi Charles, Tamar Chitashvili, Laurel Hatt, Jude, Nwokiki, and Catherine Connor. So let me start. Go ahead. Well, we'll go through. We're going to start with Jodi Charles. She's a Senior Health Systems Advisor at the U.S. Agency for International Development. She provides strategic guidance to field missions on advancing health systems, including the application of high-impact and evidence-based technical approaches. She also supports the development of country-level strategies, project design, analyses, and evaluation, and she oversaw the 3.0 revision of the HSAA. Jodi.
Thank you, Jen. I hope everybody can hear me okay. First of all, I want to welcome everybody today, this morning or afternoon. We've had such a positive response to this methodology, so we're very excited to share it with you today. I'm going to give a very brief background and overview of the HSAA and then hand it off to my colleagues who will give you in-depth sort of deep dive on some of the modules, kind of give you a sense of how this methodology actually works. So let me start by saying that this methodology, the Health System Assessment Approach, or HSAA, has been on the ground since 2006. Version 1.0 was rolled out in 2006. It's been applied in more than 25 countries in Asia, Africa, Latin America, and we've seen very positive results in usage of this methodology to inform leadership and policymakers and planners for more effective programming and for implementation of better health systems programs. But we updated it now because the last version was updated 5 years ago. Version 2.0 came out in 2013, and there have been a lot of changes in the field since then. Health system strengthening has evolved quite a bit. So we undertook a 3.0 revision, so that's what we're calling it, HSAA 3.0, as a much more collaborative approach to revising it. And Jen has shown you I think you've shown the link already. It's at www.hsaamanual.org, and I think Jen's going to do a quick demo later. But we really wanted to focus on a couple of key areas with revision. First and foremost, we wanted to update the technical content of the health system's functional areas. But we also then wanted to adapt the methodology to promote a greater focus on complex adaptive systems and how to use that to achieve performance outcomes. We also wanted to make it more accessible. We wanted to take what is essentially a very dense methodology and try to make it more accessible through the use of technology and language. So we developed a web-based and mobile platform that's much more easily accessible if you're not sitting at a computer. And then we also wanted to make it less technocratic and jargony. You can still download the PDF version, and if you do that, you'll see it's quite dense. We often refer to it as the phone book because it is so dense. But you can also use the web-based platforms to navigate through the concepts and much more easily. And so we think that's a very user-friendly way to go about it. We did update the technical content of the module. We added a section on systems thinking, and we had a much more collaborative process with this revision. We worked very closely with WHO, who was really a key partner in this revision. They worked very closely with our team to ensure that we had aligned the technical content with the right mix of qualitative and quantitative. So we're very thankful to WHO for their strong collaboration. So just to give you a quick highlight of it, the framework does draw on the WHO health system functions, but with a focus on complex adaptive systems and how to utilize that to improve performance outcomes. So it's intended to capture system-wide information for better planning. It emphasizes relationships and interactions among system functions and stakeholders. It captures both the public and private sector. It also includes the role of communities and patients as key stakeholders, and it's also inclusive of the formal and informal sector. So looking at this framework, the functions, for most of you, will probably seem very familiar, but the focus here is really on having a flexible methodology that can be used as a key data input to design better policies, but not focused on siloed building blocks, really looking at the interactions and the complex systems that influence those functions. And so it includes critical evidence on systems input, processes, outputs, and that analysis that's really required to figure out how, not just to sort of assess the system, but how do we really hone in on solutions to persistent systems barriers and how do you address those barriers for better system performance. So just one more quick thing I want to say, and you'll get a sense of this in the deeper dive, but because the methodology is so flexible, we found that one of the strengths of this methodology is that it really requires that you have a strong team and a strong process. So team makeup is very critical, having the right technical skill set, but even more important than that, having the right local expertise, people who understand not just the sort of direct health inputs, but political economy, history, institutional arrangements, all those contextual things that absolutely matter, and making sure that you've got a broad range of the right stakeholders who are not just key informants, but who are also providing feedback and validation on the results that you're providing. So it is a really strong methodology with a mix of qualitative, quantitative, and very much intended to be participatory with the countries leading and getting the right broad range of local stakeholders. So I'm going to stop there and hand it back over to Jen so we can get into some of the deeper dives and really let you see how this functions in financing, quality, service delivery, and pharmaceuticals. So thank you so much. Back to you, Jen.
Thanks, Jodi. Well, let me introduce Tamar. Dr. Tamar Chitashvili is a medical doctor and a public health professional with more than 15 years working in quality improvement, health policy, strategic and programmatic planning, and monitoring and evaluation. As the Senior Quality Improvement Advisor at URC, Tamar led the development of the service delivery module of the HSAA. Tamar.
Good morning, good afternoon, colleagues. I hope you hear me well. On behalf of USAID Assist project implemented by URC, I'm pleased to present update on the service delivery model. This is the Section 3, Module 2 in the assessment manual. But before that, let me use this opportunity to thank HFG project for this great collaborative effort. As Jodi mentioned, that was collaborative effort within implementing partners and outside of implementing partners, gathering a quite substantial public feedback, including from the WHO. So realizing that the health system is very complex with multiple interrelated and connected factors affecting service delivery processes and outcomes. At the initial stage, we developed a conceptual model of the service delivery. In this model that you see here, all supporting health system functions such as financing, human resources, pharmaceuticals, physical infrastructure, along with clinical guidelines are key inputs. These inputs are essential to deliver a range of health services at individual and population levels. Processes in this conceptual model include range of health services, managing and selecting services, and organizing and improving quality of care. These inputs and processes greatly determine health system outputs, such as access, coverage, efficiency, quality, and safety of health services, and outcomes such as health status of patients and population. Next slide, please. Continuous changes in the global burden of disease, increased prevalence of common preventable causes of ill health, and patients suffering from multiple comorbidities presented a new challenge to us to address the typically fragmented facility-based health service delivery system. The new revisions in the assessment admit essential need to move from silo curative care models that focus on disease-specific policies to people-centered integrated healthcare model. To address this new reality, the updates in service delivery model incorporate several dimensions of people-centered integrated health services. For example, it reflects range of prevention and treatment services covered, including care delivered at community level and continuity at each level and between different levels of care. The model also incorporates global monitoring indicators such as, for example, assessment of 10-year CVD risk and treatment of high CVD risk individuals. These indicators, included in the global monitoring framework of NCDs, are prioritizing total risk management approach to identify and cure all individuals with high risk of developing cardiovascular disease, rather than addressing individual diseases or risk factors associated with CVDs. This revision of service delivery model also places a patient in the center of the service delivery and puts important emphasis to assess knowledge, attitude, and practices of a population and patient. At service delivery level, patient satisfaction with health services and provision of unnecessary harmful practices were also considered as major components of quality of care. The assessment also recognizes that despite significant progress made in availability of essential inputs to deliver effective, accessible, and continuous quality health services, many process gaps prevent health systems in developing countries to improve care outcomes. Therefore, we incorporated more process measures of quality of health services when they were available. This includes understanding of both what this is the content of care and how the processes of health services are delivered, how health services are delivered. And lastly, assessment proposes updated list of indicators according to up-to-date evidence and aligned with the global priorities and monitoring frameworks such as SDGs, PMCD, Global Strategy for Women's, Children's, and Adolescent Health, emerging health priorities such as NCDs, included measures on risk factors, and harmonized them to global reference list of 100 core indicators and etc. Next slide, please. Our revised service delivery model assesses this essential health system function from the lens of universal health coverage. It explains that UHC is a pathway to achieve better health outcomes only if there is universal access to quality health services. What good does it do to offer free maternal care and have a high proportion of babies delivered in health facilities if the quality of care is substandard or even dangerous? For quality health services, waste limited resources and therefore constrain a country's ability to expand coverage to more beneficiaries, include more services in benefit package, and reduce cost sharing and fees. This, of course, can shrink the UHC cube inside. Delivering quality health services as global imperative for UHC is well articulated in the recent WHO World Bank OECD report that considered UHC as empty promise without quality of care. To address this issue, a revised model incorporates well-known term effective coverage and proposes more measures that capture quality. Such measures are, for example, drug therapy and counseling to prevent heart attack and stroke, zinc and ORS for diarrhea care. And these indicators differ from measures that simply assess content coverage, for example, contact coverage, for example, for antenatal care visits. The revised model also suggests to prioritize the range of coverage indicators based on additional prioritization criteria, such as first, the indicator assesses quality-adjusted coverage, and second, the indicator measures high-quality health services for priority high-burden diseases for the country. Next slide, please. Understanding that this holistic assessment can be used to assess health system response in particular priority area as well, we applied health system assessment approach to assess service delivery and health system challenges in emerging priority areas such as NCDs in 10 Middle East USAID focus countries. We did it in 2017. So first of all, applied system thinking, we developed conceptual model of the assessment where result chain was considered around NCD prevention and control continuum, and health system response with all its elements was considered as inputs. Similar to HSAA, we assessed health system building blocks and care outcomes, but in addition to that, considering the context of emergencies in the Middle East, we assessed health system resiliencies in Middle East focused countries to address emerging health priorities. In terms of content area, NCDs were chosen considering emerging disease burden and premature mortality in the region, but we also explored linkages with USAID's existing health priorities. And lastly, on measurement side, similar to HSAA, we looked at the standardized, globally agreed, and harmonized indicators, but also we developed custom indicators that would allow us to assess each level of the results chain and prioritize measures to adapt those to local context and assessment objectives. Next slide, please. Here we present illustration of prioritization of indicators for the assessment based on the criteria such as relevance, importance for either population or facility-based interventions, importance for national system response, and practicality. All measures were assigned score per each criteria, and indicators passing the cutoff score were selected for the analysis. Important to mention that we did not prioritize indicators based on the data availability. Realizing that this is important information for decision makers, we summarized the results of data availability by health system categories and by countries. In the next slide, please. We are presenting the results of data availability by health system categories and by countries. For example, you can see that major gaps in data availability are around service delivery indicators and health financing indicators. This information may be useful for key decision makers to understand data gaps, to make evidence-based decisions, and create clear understanding of the study limitations. This data can also inform and guide interviews with key stakeholders to get information on the areas where data is not available or accessible. In summary, a health system assessment approach is a useful tool not only for holistic assessment of country's health system, but it also allows to adapt the approach to specific assessment objective, country context, and priority focus area. Thank you very much. Back to you.
Thanks so much, Tamar. I've gotten a couple of questions in the Q&A box. Please do send those, and we'll work to get to those at the end of the presentations. So now I want to introduce Laurel. Dr. Laurel Hatt brings more than 15 years of professional experience in health economics and finance, health system strengthening, and evaluation research. She's currently a Global Health Program Director at Results for Development and a Health Financing Advisor. Before joining R4D, she was the health finance lead for HFG at Apt Associates and led the revisions to the health financing module in version 3. She also led 3 assessments in Indonesia, St. Kitts Nevis, and Grenada. Go ahead, Laurel.
Great, thanks so much, Jen. Good morning, good afternoon, everyone. Pleased to be with you to share some of the highlights of the changes to the health system assessment approach for health financing. I was as Jen mentioned, part of the revisions to the module in this 3rd update, and I'm pleased to share some of the changes that we've made. So many of the basics here actually haven't changed that much since the first version of the HSAA was created back in 2006. This module, like others, starts with a definition of health financing and gives an overview of the key components of a financing system. It provides guidelines on preparing a profile of the health financing system using a set of standard financing indicators that come from the system of health accounts. These summarize, for instance, things like the magnitude of health spending and then how funds flow through the system from the sources of financing through those who manage the revenues all the way down to service providers and consumers. And as with the service delivery module, the financing module also provides guidance on how to map the results to overall system performance criteria such as equity, efficiency, access, quality, and sustainability. Next slide. As Tamar emphasized in her presentation, the biggest change here in the health financing module as well is that this newest version is much more explicitly rooted in the UHC space. That is, assessing the ability of health systems to provide needed good quality health services to all who need them without putting them at risk of impoverishment. So the innovation of UHC is that it really asserts that financial protection is an inherent goal of health systems, along with access, quality, and equity. So one reflection of this expanded UHC focus in the health financing module is that we've added indicators of catastrophic health expenditures and impoverishment due to health spending. These are the standard WHO indicators. And there's a more extensive emphasis on reducing out-of-pocket spending as a source of financing, including reducing reliance on user fees. Another change is that for clarity and better logical flow, we restructured the whole module around the 3 core health financing functions, that is revenue generation, or also known as resource mobilization, the pooling of those resources, and purchasing high-quality care in an efficient manner. Thirdly, we provided updated links to and better alignment with other seminal health financing tools and references from other global institutions and leading academics worldwide. This includes, for example, the WHO's Health Financing Country Diagnostic, which is really an even more detailed and thorough health financing review tool. We've linked to the World Health Report of 2010. The UNICO case studies that were produced by the World Bank are referenced, And we've also provided links to new data sources like the SARA, the Service Availability and Readiness Assessments. Next slide. In the discussion of how to achieve the UHC goal of financing protection, the new version of the assessment module puts less emphasis on health insurance schemes as the singular approach to improving health financial protection. And instead, it provides a more holistic discussion of various forms of public financing and really puts an added emphasis on the importance of strategic purchasing. We've included a new indicator that highlights the risk of fragmentation across payment schemes and the effect that this kind of fragmentation can have on equity in coverage. Where there's greater fragmentation, problems like adverse selection tend to be more acute, and high-risk groups are more likely to be excluded from coverage. The tool also looks at whether enrollment in a financial protection system is compulsory or voluntary, and it encourages the team conducting the assessment to really review carefully whether those with nominal coverage, those who are on paper enrolled in insurance, are actually getting financial protection, are actually protected from the risk of impoverishment due to the cost of care, and whether they are actually utilizing services. So really a focus on the real experience of having financial protection and coverage, not just whether someone is enrolled in a scheme or not. Next slide, please. I'm going to share just one brief example of when we applied the health system assessment approach in Indonesia with a particular emphasis on the financing module. This was at a very historic moment in Indonesia. The new president of Indonesia had publicly committed to achieving UHC by the year 2019, a very ambitious goal. A national single-payer health insurance system had been launched in 2014 that unified a number of formerly fragmented financing schemes into one single-payer system, and this was really transforming the health financing landscape. With new leadership at the USAID Indonesia Health Office and with a new administration in the government of Indonesia with the onset of the new insurance scheme, USAID really wanted to take a closer look at defining a systems approach to health programming in the country across all health technical areas. And so they utilized the health system assessment approach as sort of a launching pad to consider that revised approach to programming in Indonesia. Next slide. So just a couple of the highlights from that assessment. Our findings acknowledged the enormous progress that Indonesia was making toward its goal of UHC. However, we also noted that financial protection still needed to be strengthened in the country because around 2/5 of health financing was still coming from out-of-pocket sources, even though coverage, nominal coverage under the insurance scheme was expanding. The assessment recommended that this kind of improved financial protection could be achieved in part by increasing public financing for primary health care, providing greater government-funded subsidized coverage for informal sector workers who were left out of coverage through contributory mechanisms and through subsidized coverage for the poorest individuals, and also emphasized enhancing the purchasing function. And after this assessment, USAID used the results to design a new program of technical assistance to strengthen the government's capacity to serve as a strategic purchaser. And this program of work is still ongoing today, working with the government to review and assess components of strategic purchasing and identify opportunities to enhance that function. So this is just a brief snapshot of one opportunity, but a great opportunity to put the health system assessment approach into practice in an exciting context of health financing reforms. So I'll stop there. Thanks very much for your participation today.
Thank you, Laurel. All right, let me introduce Jude. We'll go on to the next topic. This is the last module we'll be profiling. Jude Nwokiki is the Senior Director at the United States Pharmacopoeia and Head of the Promoting the Quality of Medicines, the PQM program, where he leads USP's experts in quality control, quality assurance, and regulatory systems to advance pharmaceutical quality systems. Jude's a pharmacist, and he has held multiple technical leadership positions in the health sector, focusing on regulatory and quality assurance systems, pharmacovigilance, and pharmaceutical management. Jude, I'll hand it off to you.
Colleagues, good morning and good afternoon to all. Many thanks again for joining us today. Just a few slides to introduce you to Module 4. Which is on medicines, vaccines, and health technologies. The revision of the HSAA Module 4 was done jointly by the Systems for Improved Access to Pharmaceuticals and Services, SIAPS, the SIAPS program, and the Promoting the Quality of Medicines PQM program implemented by the United States Pharmacopeia, USP. So in this slide that you're looking at right now, we want to just highlight that we'll be looking at what constitutes the management of medical products generally, including vaccines and health technologies. And I think one of the things we want to do with that is to really illustrate pharmaceutical management cycle and how that helps in the management of pharmaceuticals. Next is developing the profile of the system. Noting that the pharmaceutical system is complex on its own, even though it is a subsystem of the overarching health system. So we will look at that and then give you a quick insight into the medical products quality assurance framework. Again, a subsystem of the subsystem that is pharmaceutical systems. And we then talk about assessment indicators, particularly, highlight some changes and what is new in the HSAA version 3. Again, maybe a few comments about the findings, what you do with findings, and how you develop recommendations, and then, of course, assessment reports. But to next slide, just starting off to say that pharmaceutical management is much more than supply of medicines. Pharmaceutical management framework really defines a system-based approach for ensuring sustained access to and appropriate use of medicines. These medicines are supposed to be quality assured. So when you look at the graphic that you're seeing right now on pharmaceutical management cycle, you notice that there's an interrelationship, interlinkage of selection, procurement, distribution, use, which really are connected with management support. And that the foundation of all this is really the policy, the law, the regulations that need to be in place for the pharmaceutical management cycle to function optimally. So what you see is that from selection all the way to use, whether you're talking about procurement, distribution, storage, a whole range of management capacity are required and are necessitated by, must be put together using appropriate tools that are being validated, tried, and tested that can really diagnose what is ailing the system. And again, there has to be necessary policy and legal framework to ensure that those systems function appropriately. But I think the most important thing to mention here is a well-functional pharmaceutical system ensure access to and appropriate use of medical products so as to meet the desired health outcomes that we're seeking to achieve. Next slide. So in this slide, really, we want to give you an insight into the medicines quality assurance framework. And what's exciting about this is really a way, a way to frame how do you ensure that medical products that are available to healthcare providers and patients and to the population are quality assured. And so one of the ways we like to look at this is to look at regulation. But keep in mind, not just regulation for the sake of it or quality assurance systems training for the sake of it, but when, to make sure that they are risk-based and proportionate to the risk that you see with that product. And then we look at the sourcing, which is really essentially how to ensure quality manufacturing either within the country or products that are manufactured elsewhere and then brought into the country. And so to make risk-based regulation to function well together with the quality sourcing or quality manufacturing, you have to have policies, you have to have systems, you have to have structures in place. And in all these, the foundation is standards, international standards. So adoption of international standards is very key and important and frontal in making sure that medicine quality assurance system function effectively. In fact, I would say that this is most pronounced in the medicine, vaccines, and health technology subsystem or building block much more than it is in every place. And those of you that work in this area will recognize such international standards like the ones WHO come out with, the ICH, International Conference on Harmonization. Standards are coming from PICS and several others. And so when the system is functioning very well, you get these desired outcomes, which include really supply of safe, effective, quality assured medical products improve. Patients are protected from substandard and falsified medicine. The burden of that is very much being felt across countries where we work. And then you have the evidence base to take decisions in the system. One of the challenges that I often had is how do you connect all this to true public health impact? And now we are beginning to see data increasingly that when medicine quality assurance system is functioning very well, you ultimately have a reduced wastage, reduction in financial waste. And then ultimately there is a decrease in morbidity and mortality. When you are talking about antimicrobial agents, clearly this contributes to reducing the emergence of bacterial resistance. We build confidence in the health system. We know that in most countries, having medicine in the hospitals, in the clinics, is really what the population use as a overarching metric for the functioning of the health system. So availability of quality assured medicine plays into that critically. And then, of course, the health system efficiency is greatly enhanced. Next slide, please. So you may wonder what's new, now that SciAps program and the PKM had worked on this, what's new between version 2 and 3. So we've tried to highlight some of them in the slide that you're currently looking at across those boxes. But again, when you look at the regulatory functions, when you look at the procurement, distribution, use, you see there are a collection of indicators that have been added. And so without spending so much time to go into details about that, I want to highlight as well that in version 2, the framework for managing medical products, vaccines, and technologies was introduced, quite all right. But now in this version 3, what you notice is the pharmaceutical management system concept now was really introduced and defined. So that's why we started this presentation by really going back to pharmaceutical management cycle. And then there were explanations properly articulated as regards to the interrelationship between the frameworks and the functions. So again, why we had to look at the framework. I would like to also highlight that in version 3, particularly in the table 3.4.1, the questions to help describe and assess medical products, vaccines, and technologies within the country context. Here we are now looking at an expanded, description and responding to those questions. Some of them were kept and were rewarded, better addressed to inform on the assessment objectives. Questions were also categorized into 2 broad areas in version 3, which is the health sector and service delivery, and then national, cross-sectoral, and international context. There are several of those examples I would like to cite, but for want of time, let me just highlight on the very last one. In version 3, under medicines law, regulation, and governance, you see that now you have those indicators related to registration, licensing and inspection, quality control, post-marketing surveillance, and the rest of it. Next slide. So, some of you who have been I've been working in this area for as long as I've done, or even much longer, you will see that there are several assessment tools already exist in monitoring the performance of each component of the pharmaceutical management cycle. And they include earlier tools that really look at the comprehensive system. You will collect the rapid assessment of rapid pharmaceutical indicator assessment tool, MSH, made popular at the very early. But when you look at this slide, we're trying to show a collection of them, starting from the most recent one from WHO, which is the global benchmarking tool for the evaluation of regulatory quality assurance agencies and systems, and then begin to use those assessment findings to define maturity levels for these regulatory agencies. So WHO has got maturity level 1 to 5, where maturity level 5 is the Cadillac. But WHO says, countries to have a functional regulatory agency, you must be operating at maturity level 3. And so this is really one indicator tool that is really zeroing in on a subsystem of this subsystem that is pharmaceuticals. And then you have several others. There's the inventory management assessment tool, the procurement and supply chain tool. Some of you must remember the days of the drug use survey. Then we have the rapid assessment of quality assurance and medicine control. That's the previous program, USAID funded program of USP called Drug Quality and Information Program did. In the book, we call the Ensuring the Quality of Medicines in Resource-Limited Countries, an operational guide. So there's a tool out there to help countries in assessment of quality assurance and quality control systems. And then there is the MCAS, the WHO tool, which is for model quality assurance system, how you assess the capability of procurement agencies to be able to conduct a quality assurance audit that will inform then the procurement of medicines to be donated, and several others that are listed there. But the point of this slide is really to note that what we're recommending is a place where you're seeing the HSAA version 3 module 4 to enable you do a health system level overview. Right, the tool is most useful in assessing the interaction of health systems, particularly for the medicine, vaccines, and technologies, and providing high-level indication of system performance. Right, and then that can be used subsequently to probe deeper using these tools that you're seeing on the slide now. Many of these new indicators that you see in HSAA version 3 linked and interrelated to the rest of the health system strengthening building block, and indeed, particularly for me, that's really the value of it. So you now could see those linkages to health system building area like financing, like governance, like service delivery, and the rest of it. And when you look at this, ultimately, you can use some of those indicators to walk through real-life examples where countries are struggling either to transition from a regimen, maybe an ARV regimen into dolutegravir based first-line regimen if you're working on HIV and AIDS, or you're making those changes from old regimen in TB, MDR-TB medicine to a new regimen. So all these aspects of pharmaceutical management cycle will play out. So there is the selection and the clinical practice guideline and standard treatment guideline that have to really have those new regimens identified as the first line. There is the procurement, there is the distribution, there is the rational and appropriate use, and all these have to rely on management functions, the collection of pharmaceutical management indicators, and of course those products that are needed to come into the country need to be quality assured, so the regulatory systems have to be functional and optimal to enable that to happen. Thank you very much, and we can take questions later.
Great. Thank you so much, Jude. All right, let me introduce Catherine. Catherine's going to talk about systems thinking. She is the Deputy Director for the HFG project. In more than 30 years of experience in international and domestic health work, she's managed and delivered technical assistance in health sector reform and system strengthening on several global USAID projects, with always a focus on health financing. She edited all 3 versions of the HSAA and applied the HSAA in Angola in 2005 and also in 2010. She's also done quality reviews of numerous other country assessments. So I'll hand it up. Thanks, Catherine.
Okay, thank you, everybody. This will be pretty brief, so we can quickly move to address the questions that are coming in. And I want to thank Tamar, Laurel, and Jude. They gave us a real sense of the richness of the technical modules across all 6 health system functions and all of these modules are in section 3 of the approach. So I'm going to take you to the front to section number 1, and this is where you're going to see the presentation of the key concepts used in the health system assessment approach, like how a health system is defined, how we define health system strengthening. But for version number 3, I worked with Ligia Pina at the Johns Hopkins School of Public Health to add a new piece on systems thinking based on publications by her and David Peters, WHO, and others. And so I got some good news and some bad news. The bad news is that obviously health systems are very complex. They're interactive, dynamic, adaptive, and the functions we were just hearing about are highly interconnected. So if you want to fix one problem like counterfeit drugs or informal user fees, you realize that you really need to engage across all the functions, whether you intended to or not. But the good news is that there are system thinking methods that can help, and these can be applied to public health and health systems, because systems thinking is an approach to problem solving that views those problems as part of a wider dynamic system so you can anticipate the complexity, kind of embrace that messy reality. So in version 3, we have 3 things that are helpful here. First of all, the health systems framework that Jodi went over, that's discussed in both sections 1 and in 3, and depicts all those interconnections. Also, as I think you heard with Tamar, Laurel, and Jude, in each of those technical modules, they each highlight the links with the other modules, with the other functions. So they're always cross-referencing each other. So that's really being popped out for you as you look through the material. And then finally, we have in section 1 this new piece dedicated to systems thinking methods. And these are drawn from the field, which has evolved from many different disciplines such as biology, economics, physics, management, even computer science. And so there, what you're going to find is a table listing these 8 different systems thinking methods and explaining what they are, and then explaining how they can be applied when you assess a health system. And I thought I might just look, take a quick look at one of them, the Innovation Change Management History. I thought this is incredibly relevant because almost without exception, every country has a history of strategies and solutions that they've tried or are in the middle of trying, or it was a strategy that's sitting as a document on some shelf and never got off the ground. So knowing why these efforts did or didn't work, this is a gold mine for figuring out what to do next, like what meaningful recommendations would really be useful for the assessment exercise that you are involved in. So I just wanted to give you a flavor of systems thinking here, and now back to Jen.
Thanks, Catherine. Okay, we've gotten a good number of questions. Please continue to submit those. We have about 10 minutes, so we should be able to answer those. While you are submitting those questions, I want to invite you all to go to the tool online. It's at hsaamanual.org, and get a feel for the tool. It is all mobile friendly, and you can even save this URL and your favorites in your home screen and have it as just a quick app and access it anytime you wish. We've actually migrated the entire content of the older version into a platform called Articulate 360 Rise. And if you do any of the online training, you may be familiar with this platform. It's typically used for e-learning, and we found it to be a good fit for this kind of guide-like presentation. If you are also looking for the PDFs for download or printing, those are still available on this site. You just go to that tab for the PDF downloads, and so both versions are still available and accessible. So let's get to some of the questions here. And I would invite any of our presenters to feel free to respond. I've got you all off mute, so you can chime in as you see fit. There are a couple of broader questions about implementation. One is around how the HSAA recommendations are implemented in a specific country. What has been our experience with that?
Hi, Catherine here. I can tell you there's definitely many cases where because this approach, has been a collaborative effort among primarily USAID-funded projects, the recommendations do get acted upon in terms of USAID missions using the findings and recommendations to inform their programmatic planning. I've definitely seen that. And in particular, I think what happens and what I saw happen in Angola is that there's a better alignment between USAID's programmatic direction and the government strategy and other donor efforts, because these assessments always include a section analyzing what all the other kind of players are doing in the health system space to look for those opportunities for alignment.
Thanks, Catherine. This question's for Tamar. Could you give an example of some of the process gaps that affect service delivery?
Sure. So there are many process gaps. For example, the way how the health services are organized. And there are like many issues around that in particular health facilities, as well as at different levels of care. For example, how the referral is organized or counter-referral is organized between different levels. So all those are process-related gaps that are very easy to identify with the tools that Catherine just mentioned, for example, through the process mapping.
Thanks. Okay, I'm just reading through questions. There's another one here for Laurel. I'm going to reward Laura McGough for early questions here. Strategic purchaser idea is interesting. Could you give an example? Is this primarily for pharmaceuticals or arts, also human resources for health?
Okay, great question. This is strategic purchasing is actually almost a discipline in and of itself within financing, and it's fascinating. I encourage you to actually look at the assessment manual. There's a pretty good overview of the concept and how it's applied and what it means, what it can be used for. But I'll just give in a nutshell, the concept is really trying to look at systematically considering what to buy, so what a purchasing agency such as a health insurance agency or a Ministry of Health, what interventions, what services and medicines they wish to purchase with pooled public financing. Secondly, from whom to buy, which providers to contract with, which are the highest quality accredited providers of health services, and making sure that those are the providers offering care that's publicly subsidized. And then thirdly, how to buy. So this is looking at which payment methods to use to purchase services from a given health provider. What should the payment rates be? What kinds of contractual conditions should be put into place? And strategic purchasing means not just being passive about, reimbursing a provider for whatever services they offer, but sort of prospectively and deliberately trying to manage overall costs in the system, deliberately incentivize providers to offer certain types of services at a certain level of quality, and contracting selectively with providers that offer the best quality and the most efficiency. So these are the concepts of strategic purchasing. It can apply to health workers for sure in terms of the incentives that are offered. It can also be used to improve the efficiency of purchasing of pharmaceuticals, as you mentioned. So happy to chat more offline if you have other questions on that.
Okay, here's a question from Jacob Hughes at MSH. What should be done with the findings of the HSA assessment if they do not correspond with available funding, be it donor USG funding or country budgetary structures and amounts?
Great question, Catherine here. I would say that the finding, those aren't good findings in a way. I mean, a really good health system assessment would take into account kind of the macroeconomic status of the country and the fiscal health of the country, and should be producing actionable findings. It should have, those findings should have taken into account what's financially possible for that country at that time. And because I think often these governments get a lot of aspirational, wouldn't it be wonderful if everybody had everything today types of recommendations, but what we really are looking for with this approach is for the team to take into account the realities and make their findings be something doable within the budgetary constraints that exist at the time. As well as the donor, kind of the donor parameters.
Could I jump in also? This is Laurel, with an additional thought on this, because I think, almost always the the set of possible recommendations coming out of an assessment are going to probably exceed what's feasible and affordable at any given moment, because resources are always constrained. But part of what we try to do, or what we have tried to do in some of the assessments that I've been part of, is to think about the sequencing of recommendations as well. Sort of what are the starting points? What are some of the fundamental reforms that need to be made? What are the low-hanging fruit, and what are the more aspirational goals? And so if you can break down the set of recommendations with some kind of prioritization around feasibility and importance, and that can also, obviously it's up to the audience of the assessment, the government stakeholders and the mission and so forth to react to what the recommendations are, but if you can give some guidance about how to prioritize them, I think that can also be useful in fitting the recommendations to what the resources available are.
Thanks. Okay, question from Lisa Nichols at APT. The HSAA can take considerable time. Has the version 3 streamlined or introduced efficiencies to help when you are in a low data or information country situation?
So this is Jodi. I think that's a great question, and it's been part of longer-term discussions. We have looked at how to better, first of all, information is better than it was, 10 years ago when we started doing this, even in low data countries. So part of how you craft the HSA for a specific country involves recognizing what the information, data, and political constraints are. I know we've had some that have taken quite a long time simply because the government, Ministry of Health, has been very engaged and very involved and had several layers of approval. Those are the kinds of contextual factors that you actually want to make sure you're taking into account. You don't want to have an expedited assessment at the expense of stakeholder buy-in and involvement. That's part of that's why the process is so important. You want the country to use those recommendations, and so they have to be involved. But we have had much more success, and this is just globally, with condensing data and information, making things more usable, and incorporating that into the pre-assessment, the sort of zero draft desk reviews that get done, so that, and that's absolutely critical to efficiency. So making sure that when the team hits the ground and is doing informal interviews and talking to people, that they have done all of that work ahead of time, so they're not playing catch up and they're not kind of caught unawares as to what the latest data and information is. So it really is in the preparation and the sequencing of how you do the HSAA to maximize efficiency, and then taking into account the political, the economic things that you learn in the country that could actually extend the timeline. Others who've got Laurel Strautman might have additional experience on that.
If I may add also two major points. One, the assessment proposes existing data and existing information in the country available for the assessment, but supplements the issue of data availability with key informant interviews that are being used to identify and address and get some information on existing data gaps, including qualitative data, as well as seek some more specifications and clarity on the issues in case of data quality or not comparable or different sources of data.
Well, thanks. We're going to have to close with questions at this time because we've already reached the 10 o'clock hour here in Washington. I want to close with just a couple of plugs for end-of-project resources. As you may know, HFG is ending September 30th, but our website will not. So please, I welcome you to go to our resources page. We've got a lot of great resources posted, including the knowledge and learning briefs from our HFG Advances series, podcasts, hundreds of publications, and video recordings from the Roundtable series and all of the sessions that were presented at our end of project event in May 2018. This webinar will go out to everyone who is registered probably next week, and it will also be available for download here on the website as a video resource here. You can click on that video icon. Next slide. So I just want to thank all of our presenters for sharing all of their expertise and thoughts today, and all of you for joining. We really appreciate you taking the time to learn more about the HSAA. Have a great day.
Thank you.
Thank you.